Remember Edna, our gardener with diabetes and heart failure? Her diabetes is right there on her problem list, typed, spelled correctly, sitting in the chart. And on its own, that proves nothing. Every risk-adjusted diagnosis lives or dies on one question. Does the note actually support it? The industry shorthand for that support is MEET: monitor, evaluate, assess, treat. 4 kinds of proof that a condition is real, active, and being handled this visit. Here's the part people get wrong. You do not need all 4. Any one of them is enough. But one of them has to be there in this note from this encounter. M is monitor, signs, symptoms, disease progression, or stability. In a real note, it sounds like this: A1C stable at 7.2, diabetes well controlled, continue current regimen, recheck in 3 months. That one sentence shows the condition is active and being watched. That is support. E is evaluate, reviewing test results, medication effectiveness, response to treatment, chart language, echo reviewed, ejection fraction 40%, symptoms improved on current dose. You are watching the provider weigh evidence about the condition. That counts. A is assess, the provider's clinical judgment about the condition, ordering tests, reviewing records, counseling the patient, chart language, chronic kidney disease, stage 3, discuss dietary protein restriction, will repeat renal panel at next visit. The condition is named and reasoned about, not just listed. T is treat, medications, therapies, referrals, procedures. Chart language, increase lisinopril to 20 milligrams daily for hypertension, or referred to nephrology for worsening kidney function. An order, a change, a handoff. Something the provider actually did about it. Now the trap. A diagnosis gets added to the problem list in 2022, and the record faithfully copies it forward into every note since. Nobody has monitored it, evaluated it, assessed it, or treated it in 2 years. It is just there. Code from the problem list alone, and you are submitting diagnoses with nothing behind them. That is exactly what auditors pull first. Same story with a cloned assessment. A diagnosis pasted in with no plan attached is a red flag, not support. And the rule people forget every January: risk adjustment resets every calendar year. A chronic condition only counts if it is documented and coded from a qualifying face-to-face encounter at least once during the year. Diabetes does not carry over. Amputation status does not carry over. January 1st, the slate is blank, and every chronic condition has to be supported again. Once a year is the minimum, not the goal. If you want this as a checklist, you can keep open while you code. We have a free plain English MEET reference at hccbuddy.com/MEET criteria. It walks through all 4 letters with more chart examples for the big chronic conditions: diabetes, heart failure, CKD, and the rest, in the exact phrasing that holds up when somebody asks you to prove it. Keep it open in a tab, and when a note looks thin, you will know in about 5 seconds whether it is codable. Support the code or do not submit the code. That is the whole standard. Thanks for watching.